right, Dr. Casterman, I think we're ready.
Okay. Let's go ahead and call to order the Protocol Medications Devices Panel Committee meeting for November 16th at noon. Shelley, can you give us a roll call, please?
Amber Wright. Aaron O'Connor. Brian Smith.
Present.
Chester Key.
Present.
Chester Franco Casterman.
Present.
Garth Gamer.
Present, thank you.
Heather Miller, I saw you in the chat. Ethan Johnson. Okay. Josh Gaither.
I'm here.
Mark Hansen. Matt Shaw.
Here.
Paul Dabrowski. Hey, Paul, can you just chime in when you get a chance? Philip Hannon
Here.
and Shari Grand.
Here.
Aaron O'Connor.
Here.
Oh, thank you. We have four.
All right. Shelley, do you have any housekeeping announcements before we start?
Please be advised, we're going to record this meeting. So anything said, anything shared in the chat, or being on the cam will be recorded publicly.
All right. So for the attendance report, that's attachment 3A. Please remember that if you miss 2 consecutive meetings, the Bureau will contact you to ask if you're still interested in serving on the committee. As far as the vacancy report, there are no vacancies to report at this time for this committee. And we'll go ahead and start with the Bureau report. Chief Garcia.
Right. Well, good afternoon. We wanted to start out today by giving a warm welcome ×3 to some of our new Bureau staff. I think there's some new folks joining us, maybe not in the room, but online. And I'm going to reintroduce. We have Ariel, who is our epidemiologist that has just joined the Bureau. We have Aubriana, our new EMS coordinator, and Karen Barnes, who is our newest CON and rates team member. The Bureau is growing. We have quite a few new staff and also recruiting for some additional vacancies. We're really looking forward to our new team members working with you all, and thank you for joining us. I am going to go very, very quickly through just a few slides since we are sharing the slide deck out with everybody. We want to acknowledge again Crash Responders Safety Week and the theme, protecting those who protect you. We just can't thank our responders enough for what we do, taking care of motorists and clearing roadways every year. Over 120,000 traffic related crashes last year, and actually 1,000 fatalities, very sadly. Moving through the slides, I can't stop plugging this. The team has done a tremendous job, both HEPI and STAB, as well as the Department of Health Services team, of putting together the new trauma dashboard. We have not only a trauma dashboard with a new trauma snapshot to share with you all, there's also a couple new dashboards, including a motor vehicle traffic related trauma dashboard. You can drill down by year, you can drill down by injury, and we want to keep promoting those dashboards because it's very good information that's actually available by region. Moving on, we'll keep rolling through these slides. And we'll stop on a rulemaking update slide just to make sure we're sharing with everyone on this very next slide. Shelley, one more. We have several completed rulemakings in the last couple years, and we want to thank all stakeholders that have participated in that process. EMS scope of practice was last updated in 2022, and this year air ambulance rules and trauma center rules were updated. The pending rulemakings are on this slide. We continue on with the ground ambulance rulemaking. That is ongoing. The department filed a notice of proposed rulemaking back in September. And that packet is still pending. We have not put that forward to be on a GERC agenda yet. We will certainly keep stakeholders updated on the status of that rulemaking. It is ongoing. The next set of rules we're going to be looking at We heard a lot of feedback today from the education committee. We are going to be looking at EMCT certification, training, and scope of practice rules in 2024, and beginning to get ready to get some rules in play for EMR ambulance drivers and a critical care paramedic pathway. So thank you in advance for all the participation on those big updates. And beyond that, let's do naloxone leave behind. Dr. Bradley, would you like to do the honors?
Sure, I will cover this very briefly. So the naloxone leave behind program is live. If your agency is interested in participating, please reach out to Adam Rodriguez. We do have a few agencies that are already distributing these kits in the community. So thank you for everyone who has shown interest in participating in the program.
Yes. And Shelley, can we jump to slide 17? Next on the agenda is the EMS and trauma needs assessment. We want to thank all of the regional councils and associations that have participated in the strategic planning needs assessment process so far. We are listening, learning, planning, and prioritizing, and then doing, with the goal of coming back to our statutory committees before 2025 to get adoption of the statewide and regional strategic plan. We have had over 1,000 participants take part in the surveys and focus groups thus far, and we really appreciate everybody's work and commitment on this big thanks to the region. I think the last slide I'll cover before I turn it back to Dr. Castro-Marin is slide 23, Shelley. We are going to be hosting House Bill 2609 regional meetings. They'll be offered virtually via Google. There are dates on the calendar and flyers that we've shared with each regional council. We hope that you'll join us December 4th through the 7th. The target audience presents really is our CON holders, and we'll look forward to sharing some updates on what to expect with some of those new requirements, including GPS requirements and waivers for each vehicle per the new bill, as well as response time reporting requirements per the new bill. Those items will be effective January 1st. So please join us in December for one of those regional meetings. I think that is all I have. I will turn it back to you. End of Bureau report.
Thank you. Nothing you want to cover here?
Oh, you know what? Do we have Carissa on the line to share information about Quail Kids and some of the projects that you're working on?
Yes. Hi, good afternoon, everyone. So the Bureau has noted an increase in ATV incidents over the last few years. And because of this, the DQA team and some of the other Bureau members have started working with the Arizona Game and Fish Department to try and promote an ATV injury prevention program. They have a program currently called Quail Kids, and so we're working with them to kind of use that as a baseline and do some updates. And then the goal is to have trauma centers be able to work with them and use that program for prevention outreach. So we did a pilot program with Mount Graham, and they were able to give us some feedback on how that went. So we're taking that feedback and applying it to the program. And we'll make sure and keep you guys updated and post any updates we have as we continue working on it to our DQA webpage.
All right. Thank you, Carissa, very much. And welcome to the new team members as well. Thank you, guys. It's a pleasure to meet you. So for our discussion and action items, can I have a motion to approve the draft minutes from July 20th? So moved. Thank you, Brian. Can I get a second?
Second.
Thanks. Thank you, Dr. Johnson. Any discussion? All right. Hearing none, all those in favor of approving the draft minutes, please say aye.
Aye.
Any opposed? Any opposed, say nay. All right, thank you. Those have been approved. Next, if I could have a motion, please, to approve the updates to the bylaws, which is attachments 5B. So moved.
Second.
Thank you. Any discussion on reviewing these bylaws here?
This is Erin O'Connor. Just a point of kind of more writing. I didn't see EMCT actually defined in the beginning of the document before the abbreviation was used throughout. Did I miss that?
Yep, thank you. So defining the abbreviation EMCT.
make that better. Yes, number 6 on the first page, there is a star. The junctions from the emergency, and to double check with school language, but I think emergency mental services, is that what that question's about?
Yeah.
There was something on that. I have it in my notes are back in the office. I found a place where this is defined, and I don't think that if we did that, then it won't meet that, but I'm trying to remember where I found it. Oh, well, that language came from Medical Direction Commission, the statute and Medical Direction Commission. There's a sentence in there that refers to this, and I think probably we need to keep the same, but I also left my phone in my car with all my stuff in it. So
So the proposal is to change it to just medical services?
well, my question is, can we change it? Because I think that line item is the font has its own language for Medical Direction Commission. And so should we be changing that away from what the statute says in there?
In the bylaws or somewhere else?
It's in the statute under Medical Direction Commission that defines what they do. I think if we change it to this, the way this is reading, it will no longer match that line item in the Medical Direction Commission's responsibilities.
Are you referring to removing emergency specifically or the other end as well?
I would have to see the statute. I don't remember exactly how that's split. Can we look ARS 3622 real quick and
And
We should tell assist the director in developing medical protocols governing the medical treatments, procedures, medication, and training and techniques that may be administered or performed by each classification of PNC. Okay, we're
that's a different line, I think.
okay.
So the concern, Brian, is with the entirety of line 6, number 6, or just with the?
Well, because I thought I looked this up and found it where it says specifically recommend medical standards for non-physician pre-hospital treatment and pre-hospital triage of patients requiring emergency medical services.
Mhm.
And that was pretty much, I thought, verbatim from MPTs.
Okay. All right, so
Maybe not.
so basically all the edits to EMPT are you're concerned that may be problematic.
Yeah.
Okay.
Or maybe it was maybe I also found it in the Medical Direction Commission's bylaws. That might be also where I found it. Can you pull that up?
Yeah.
While we're reviewing that, does anybody have any additional comment on any other edits?
I can just give a little bit of background. We do need to add on page 2, the requirements, safety, and standards of conduct. We just had some members of these commissions that would not take the required courses. And so this is required if you're on a public body, and so because these are open meetings, rules that apply. So we wanted to make sure this was added to the bylaws just to help ensure that people do that.
Under section 2.
Yes.
On the screen right now is the medical direction physician bylaw.
Yeah, so it's referring to emergency medical care technicians that are so far there.
Like since the last bullet, I think medical standards for non-physician treatment.
there.
That was the one.
It's over both the wording there. Second bullet from the bottom, medical standards for non-physician hospital treatment and hospital triage of patients requiring emergency medical services.
Nothing's gonna be that cheap.
Well, I think
And we're making a bunch of
Thanks,
changes.
here.
That would be different than what
Yeah.
MDC is.
Sure.
FYI, I just muted a couple people, so if you're trying to speak up, you will need to unmute yourself, but I believe it's background noise.
Is there a reason to remove the word emergency there?
That's a separate, I think that's a separate, separate suggestion.
Yeah.
So, if memory serves, I think I was the one who suggested the verbiage cleanup from, I didn't understand where that term non-physician came from, and it seems pretty outdated. And so, but I didn't make any comments about the removing emergency. So I think those may have been two different, inputs from members of the committee.
And I think the reason the non-physician is in there just historically is the Bureau of EMS doesn't have any authority over physician,
Yeah.
just from a regulatory perspective.
Yeah. Yeah. All right. Well, I could certainly withdraw my part of that suggestion if anybody remembers contributing to the removal of emergency. It sounds like we should keep it if the goal is to keep in line with this.
Well, yeah, because I think the original version of this matches what that says.
Yeah.
And so.
Okay. So then as an amendment, we'll say strike all the edits to bullet point 6, except for the review and recommend. I think that's still reasonable, right? And then everything beyond that, we'll remove those.
Does EMCT include EMRs? If it's not visits, like the term EMCT would not include an EMR, correct?
If we added it to Article 3, then I think that Article 3 and 4, I think we would be
We
good.
covered, okay.
All right. And then does anybody have any comments on the roster list, adding 3 members there? Else looks pretty good. All right. Any further discussion on the phone? Hearing none. All those in favor of adopting the bylaws edits with the removal of the edits in line 6, except for the words review and. All those in favor of adopting those?
Sorry, one quick thing, just because it's, as we make people aware of 2 items on. So Concord pointed out there's section 2 terms of membership, so requirements for taking the court. And then also on page 3, voting by email shall not be authorized. We also have requested, just from open meeting law, that if you are participating, we have to capture your attendance either verbally by a cell phone, on the computer by Google Meet, or typing in the chat to the microphone is not working. So we just needed to make sure we were capturing that because we have issues with attendance. And then on page 3, just updating a little bit about the chair language and just kind of recognizing how that is appointed to the.
The members shall consist of 14 members. Now we've added 3. Should we amend that to say 17? Committee shall consist of currently there's 14, but we've added 3.
Is that intended to be a minimum of 14?
Well, the following numbers are required right before.
Oh,
and if you're
I see.
requiring, we have to.
I see.
And a couple of things in this, I definitely appreciate as much involvement that we do change the form numbers. They're just kind of from an awareness perspective. The more members you have, your quorum also changes. And so we do have several of these positions already covered on the committee. And so if we add this, do we start to potentially get into issues with quorum? So it's kind of one of those things to consider. We do have several medical directors on. We do have paramedics on as well. Just kind of as we look to add, are we really adding a specific category that we don't have already covered?
You saying like, if you're a medical director and also on HCC, they have 2 for 1, so we really don't need to count 17 because. Yeah.
We would need to change that to 17 members though, too.
Yeah.
Yeah,
Right.
so if we would update that. So I just want to make sure from perspective of looking at the total numbers, because PMD is usually really good, but occasionally we've had issues that we canceled and we can vote on items if we lack a quorum. So with these additional categories, are we adding something specific that we don't really have represented? I think there's quite a few EMS medical directors as well as paramedics. The one for the regional rep, there are several of those that are non-medical director representatives. I don't think we have a pediatric emergency medical specialist, but that would be one, although we've had challenges. That's the other component. We often have a challenge of getting that participant.
It's either from members are required, like if we can't get a pediatric emergency medicine, it's that we list it as required. Or it should be following members are recommended, or.
So right now, 1 through 14 is what the bylaws say we have to have on the committee. So these are 15, 16, and 17 are proposed additions to the committee.
Whoever made those recommendations, did they have a strong feeling on why? Because you're right, like they're already, a lot of them already are made up within the list, but already exist, except for the pediatric one, I think.
And so long, the work group.
Okay.
I did bring up particularly the question about the pediatric emergency medicine physician, because it seems like there aren't a whole lot of those out and about, but maybe I'm wrong. But I know that's been an issue during the trauma rule revisions on requirement for board or a fellowship trained pediatric emergency medicine physician and so on. So
we just had struggle. We've had some trouble getting some that we've had people who take as a role, but just participation has struggled a little bit. So, right. The responsibilities. So.
We almost really don't need 15, 16, 17 because we're already filling it.
Right.
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 So. We should strike it then, or because the
It would be the only one that I feel like we should have, if it's possible to even have. I don't know if it is.
Does MDC have a specific spot for P? Yeah, no, either. Yeah, I mean, I would definitely be hesitant to put the P one on just because I think they're more likely not to participate. That would just always being your quorum every single month, but
yeah.
I don't feel strongly about having any of them.
All right, so is there a motion then to amend this by removing those 3 bullets? Johnson?
Yeah. I would
Dr.
prefer
Smith, Mr. Smith, that's fine. So we'll go ahead and all those to approve that amendment, say aye.
Aye.
Any opposed? All right, so we'll have those 3 stricken. Anything else to comment on specifically? That'll keep the language above at 14.
Correct.
This is Erin O'Connor. Is there any need to indicate that any of the physician members need to have an unencumbered license or there's no disciplinary action or investigation into any concerning behaviors, I guess? I didn't see that in this document.
I don't think any of our bylaws has that as a specific item.
Yeah, we haven't included that historically in any of our bylaws.
Okay. All right. Yeah, I just thought I'd raise the question. So.
Any other comments? Discussion? All right, so just to summarize, the next vote is to approve the bylaw edits and changes here. And that includes the amendments we made on number 6 on page 1. We keep review and the rest will have the edits removed. Page 2, item section 1, the 3 proposed additional positions will be removed. The language at the top of section 1 will remain at 14 members. Section 2 language would remain as shown in red. Section 4, as well as Article 5 chair language. And that is it. All those in favor of approving, say aye.
Aye.
Any opposed, say nay. Okay, that motion carries. Thank you. Next item, can I have a motion to discuss, amend, and approve the EMR training curriculum, which is attachment 5C? Dr. Wright. Thank you. Mr. Smith.
I can give a little bit of background on this. We did spend quite a bit of time at education committee, but we definitely like some feedback to this group as well. And we do not need to assume this. We're really just looking for feedback. My apologies if the agenda does not capture that correctly. A little bit of background on this is that with the passage of House Bill 2609, there is the addition of the EMR standard for the state of Arizona for kind of 2 clinical scenarios. One would be for interfacility transport as one of the 2 providers on the ambulance. And the other one would be for rural areas of less than 10,000 individual population. There are 2 ways to get the certification. That is going to create the EMR certification in the state of Arizona, which we did not historically have. So that is going to be one of the components with additional requirements above the National Registry EMR requirements. So what you see listed here at the top of this include the additional requirements, including emergency vehicle driver training, cardiopulmonary resuscitation training, AED training, training the use of non-invasive diagnostic devices, including blood glucose monitors, pulse oximeters, and training and obtaining patients' vital signs, including blood pressure, pulse, respiratory rate. So these are the elements that are outlined specifically in the House rule. So a huge thank you. I don't see Dewey in the room now, but Dewey is one of our bureau staff who came from Iowa where they had quite a few EMRs, and he helped to oversee and provide some of that training, pulled together from the national curriculum what is there nationally, and then added in some of the additional requirements from the House bill. So this is the initial proposal that is being put forward. We really just want to get this in front of as many different groups as possible to get feedback. The questions I'll summarize that came up to the last meeting is, when does this actually go live? So this can technically go live in Arizona January 1st. The reason we're pushing this forward is currently we don't have the certification level. So when we do get permission to open that pool, this will be a 3-foot process to try to get the certification approved. There is the option that an agency medical director can approve someone to be an EMR as an awareness for the medical directors in the room. If you were to approve that, you would be approving not just their medical training, but you would also be approving their driver's training curriculum as well. So that is something that I think, at least I speak for myself, not something I feel trained or equipped to approve someone to do. If someone is approved to be an EMR under the medical director pathway, that would only apply when they had that medical director for that agency. So if they were to switch agencies or that medical director changed, that certification would not be in place. There's just a few kind of clarification pieces that came up. So that is some of the background. I will open it up for anyone to like to provide feedback or discussion on that.
I'll just repeat some of the comments I had made earlier. I just would like the scope of practice that leads mirror the training that we're giving in other certifications like EMT training, which would not include things like mouth to mouth and would include things like SMR and other things that we consider standard practice in most of our local training curriculum. So things like that I would like to see as part of the scope of practice. That was my main comment. Thank you.
Any comments on the phone?
I can share some of the other feedback we got at the education committee just to get an idea. We also were asked about, is this a potential bridge to EMT? But certainly this is kind of the pathway that many states have taken, where you get someone initially in an EMR program and then you develop some type of bridge to get them to the EMT program. So as we build this out, that certainly would be a goal. The question that came up line is how would this look in rules? I think TJ did a very good job explaining this. This is really just trying to kind of give people, I know many of us, because we don't have EMRs, we may not know what that training looks like. So it's giving a broad overview of what that training does look like at a national level. The rule component would obviously look like our typical rules, where it outlines hours, any specific requirements, et cetera. It wouldn't have this kind of extensive format. And then we did have quite a bit of discussion about age limit, just because we do have some states that are lowering the age to become an EMR. And so that was one of the discussion pieces that came up as well at education. So just some of the good discussion we had there. There was also a question about how many people are currently nationally registered as EMRs in the state of Arizona. TJ had pulled the data. There are currently 150 nationally certified EMRs. And so then the question became, how would you potentially bridge that for the district certifications? So really good conversation, but wanted to make sure that we get this in front of as many individuals as possible. We can help draft something before we get the whole process. Because this will go through the normal rule writing process. So in this case, and make sure everyone knows, we will not be bypassing that.
All right, so just to clarify, this is not in front of the committee for any approval today.
Right. Yes.
All right, so the next item, can I get a motion to, so the next item also just review then? All right, so so the next item then is just a discussion of the critical care endorsement training curriculum, which is attachment 5D. Thank you. So we have a motion and a second to discuss.
I can give a little bit of background on this as well. So as part of the rule update that is currently in process, there has been some inclusion about a critical care pathway for reimbursement as well as staffing. And I think many of you we've discussed in this group kind of how we see the importance of the critical care pathway in the state of Arizona. And so we have got sufficient rule writers to start working on developing a critical care endorsement. I think that there was really good discussion and questions about why endorsement versus certification at the previous meeting. And part of that, there isn't like a national registry critical care certification. So the plan would be an endorsement, which many states have adopted, which would kind of outline specific training that's required, along with a specific national certification exams to take. So we have really good feedback as well from Education Committee. I was just getting thoughts on that. This is a huge thank you to Adam and Marissa. I know you helped quite a bit with this as well. And several other team members. TJ, I think you're on the line to help with all of these as well. Really pulling together some of the acronyms, tell us. I don't know, Adam, if you wanted to share some of what you pulled together to draft that.
Yeah, sure. So because there is no current formal recognition from National Registry towards critical care paramedics, that is taken on by the board of the International Board of Specialty Certifications. They, through them, they have a board called the Board for Critical Care and Transport Paramedics. And what they are the largest body that's often recognized as critical care certification. And so a lot of this draft curriculum is reflective of those standards, those not national standards, but those standards that the IFBC has established for critical care paramedics. I encourage you to go to their website because this draft contains a little bit, sort of an amalgam of a couple of different types of their critical care certification. I think there's more discussion needs to be had on what topics of ground education, what topics of flight education, what that would look like. So the IFBC sort of encompasses all of those. You have to take a look at what you'd like to include in those, and another, as well as the continuing education requirements from that same body as well. Mary's got her hand up.
Go ahead, Shari.
Yeah, just a quick question. So recertification is every 4 years? I just didn't know where they came up with that.
Yeah, that's what's recommended by that BCC TPC is that FPCs, critical care personnel, are update those certifications every 4 years.
Josh.
Sorry, forgot to unmute. Several questions. Second, that one that Shari mentioned. This really does need to outline how many years, and I'd really look towards a more annual CE requirement. 100 hours of CE is a ginormous amount of continuing education for anybody, much more than physicians or anybody else has to do. So I'd encourage you to maybe reconsider that and lower that level. Several comments, and forgive me, maybe this is too into the weeds, but I'll start at the top and work my way down. Number 5, under staffing for ground ambulances, I'd really encourage, although we don't register or oversee nurses in the Bureau of EMS and Trauma, I really do think that nurses, like paramedics, require additional training in critical care, and would feel strongly that this document should outline something to that effect, that registered nurses should have an additional endorsement and additional training in critical care services should they be counted towards staffing on a critical care ground ambulance transport apparatus. Some smaller things throughout I think are not a big deal. One of the topics that I did want to take a little bit of a look at and encourage some revisions to is that number 7 right there. These are incredibly vague. This isn't, I don't know what advanced anatomy and physiology for toxicology means. So I think there could be some significant revision to this one, specifically addressing specific toxicologic emergencies that we actually see in the critical care transport and scene response areas. Looking at things like aspirin, Tylenol, antifreeze, organophosphates, the normal list of things that we do in the field. I think that would improve some of the stuff here. I think that was the major things that I wanted to comment on. Oh, I'm sorry. I did have one more. My bad. I wasn't sure where we came up with the 200 hours of training for this. The hours seem somewhat randomly derived. So I had a suggestion and obviously to consider. Almost all community college and universities have standards through which credits are offered. A 1-credit class is basically 45 hours of contact time. So maybe you would consider some derivation of 45 hours so that students aren't paying for extra credits or similarly being taught more work than they thought they were getting into. So I would look for a minimum of something like 160 hours, increasing some of their clinical time on this. I think it's currently listed as 40 hours in the ICU or field. Consider maybe increasing that and decreasing the didactic time to something like 135 hours. So.
Adam, those numbers came from the IDSC requirements, correct?
Which set of numbers?
Your hour requirements. I know the recertification for IDSC is 100 hours.
Yeah,
And then the other one is this 200 in the IDSC.
the initial came from draft rules 3 and 4, article 3 and 4, from what was recommended.
Okay, thank you.
There is no requirement for any study, is there? You can go challenge.
No
the
requirement
test
for any
at
study.
time, is my understanding also. So if we write the rule, if the rule ends up being you can walk in with the certification from that board. There's, you can, as long as you can study and go pass the test, then you get the certification. So, and FDC is the same way. I do have one other question though, because there's a blending on the EMR and the EMR thing about being in rural communities, less than 10,000 people and so on is a separate, that's in 2609. There's that separate piece of legislation that was run the next year. It's 1711 or 1177 or something like that, that addresses the requirement, the nurse, where previously with the nursing boards, I think it says something about trainees in the emergency or pre-hospital nurse, which is there's a white paper from the nursing board, I think, on the training that goes in there. Can you make any requirement based off of that rule now that says any nurse can do interfacility transports? to require them to have any extra training? Because that's, the whole idea was to get rid of that pre-hospital nurse title through that legislation so that whatever agency sponsored that could just use any nurse to be able to do that. So would you?
Brian, I am not familiar with that part of the bill. If you're talking about Senate Bill 1711, you can take a look at that. I'm not familiar with that being captured within that one.
Because that's the one that allowed on 2609, I don't think there's a provision for interfacility transports for EMRs in general, other than it meets that rural community less than 10,000 definite stuff in there. And it was 1711 that allowed them to do any an EMR or a nurse do any interfacility. And I don't know that it was going to allow any extra definitions or training requirements to go in there as part of that. Because that goes in effect on January 1st, I think also, doesn't it?
Was your question related to EMRs or nurses?
He was saying that for critical care transports, there should be requirements in here for a nurse. But my question is, in light of 1711, should you do that?
Yeah, 1711, the way that I read it, is very specific to emergency medical responders and emergency medical responder training and who can authorize an emergency medical.
I think
responder.
there's the thing about being able to utilize any nurse on it too also, but we can.
Yeah, I'll
We
try to
can
pull that
deal
up
with
so
that
we
later.
can circle back on that one.
It is typical that flight companies ask their nurses to complete some additional certification in the sphere of emergency
Well,
medicine.
a lot of that came from the white paper from the nursing board. But this isn't about flying. This is about being able to do any ground interfacility transport and use an EMR or a nurse, and it no longer has the same language that was in, because it's rewriting. 2609 did some changes, and 1711 makes more changes in there because it was run at a different time. And it goes back and revises some of the stuff that was actually done in 2609. So you got to piece the two of them together.
More versus
And I just had one thing. I forgot that. So I forgot to mention during education is when we open scope of practice, or I'm sorry, yeah, when we were talking about opening up rule for that, we may want to consider, because we're talking about it here, having the STR for a paramedic to include chest suit placement. That's currently not within their scope at all. So we would need to add that in the next time we do rule. So that way we don't approve all this and then have already opened and closed rule, and then afterwards find out that, oops, we approved something that they can't do.
Yeah, so you would have to simultaneously open certifications, training, and
Scope of practice, right?
because all three components are kind of wrapped into any additional both EMR and critical care endorsement. We need scope of practice for both of those, along with the certification and training. So that's what we're trying to just get this out to get as much feedback to start looking at things. So that way we hopefully capture those things before we get to the full ready time. Yes, they all have to be able to address that.
Any other comments on the critical care endorsements?
I just have a follow-up comment to Brian's questions about Senate Bill 1711, which was follow-up to House Bill 2609. It did not change the definition for ambulance attendant in statute. And so all the references related to nurses have stayed the same. And an ambulance attendant means any of the following. There's A through E. It's just to have the reference, ARS 362201 6D has not changed. That still reads a professional nurse who is licensed pursuant to Title 32, Chapter 15, and who meets the State Board of Nursing criteria to care for patients in the pre-hospital care system.
Are you looking at 1711 or are you looking at the statute?
I'm looking at Senate Bill 1711.
Okay, maybe there's another one floating around out there. I'll find it and look at it.
Yeah, we'll circle back, but
All right, so just a reminder, this is not an approval voting item. And so if there's no other comments, we'll go ahead and move on. Thank you for for all of the thoughtful commentary there. The next item is to review the approved T3G guideline for behavioral health. Can I get a motion to review that? Right. Thanks. Thank you.
I can give just a little background. Typically, we do try to have the guidelines go through PMD for feedback before MDC. Because of the EMS Council group on alternative destination for behavioral health patients, and the fact that we have kind of got the recognition that agencies can do this already, we didn't want to have to wait till this committee met and then not wait until the end of January for when MDC meets to kind of do the final approval. So we did, MDC did review this. They made a very some minor changes, kind of specifying under the exclusion any notice suspected toxic injection or inhalation, including OTC and prescription medications. And then they cleaned up the formatting at the bottom a little bit, just from a cleanup perspective. So those were the only substantive changes to what we've had up as an optional guideline. So again, any agency that wants to do alternative destination for behavioral health, this is purely optional, but we did want to have something that was approved at a statewide level for agencies that want to implement that program.
And so this is not open to any edits at this time?
We could certainly, if we want to provide edits, that could go forward to FBC, but it isn't. Right? We just wanted to make sure the city has to be that.
So with that being said, I just had a couple of, I guess one question to start with. At the very bottom, transport to behavioral health facility for substance abuse being listed as an indication, alcohol, drugs. Did that not conflict then with the line above that says any known or suspected toxic injection, or inhalation?
So we got quite a bit of feedback from Dr. Walter on kind of the verbiage of that. With his recommendation to use the toxic injection, with the toxic being that is beyond just someone who's maybe utilizing alcohol or drugs and wants to get treatment. So we didn't want to preclude this from someone who has a substance use disorder but would like to go directly to a facility to get detox.
All right, so that's a training issue then to understand the nuance in the verbiage between somebody who's intoxicated with alcohol versus a toxic ingestion, we'll say like acetaminophen or something.
Correct.
Okay. So then I would suggest changing the bullet hypoperfusion to signs of hypoperfusion. And then also, I mean, pretty much everything here is based on clinical assessments and vital sign assessments. I mean, would it be best shown as an EMT? I mean, everything there is an EMT scope of practice.
We did discuss that. I'm trying to remember, for those of you that were at SDG, we discussed that,
I
correct?
think it was the education of the PMT versus the paramedic.
Yeah, I think it was,
Isn't it-
yeah, people being uncomfortable with not having a paramedic and stuff.
Right, and I think that's really what it came down to. Like,
Okay. And then also requiring medical evaluation. Is does the EMCT evaluation meet that qualification, or does that mean hospital medical evaluation?
Hospital medical evaluation. So that wasn't changed. This has been the version that the Bureau have had for years now. The only changes were just the toxic ingestion line, and then the bottom with the feeling that if someone has kind of a new complaint, so if someone has, a chronic ankle injury that's not new
Sure.
inflammatory.
All right, but medical evaluation means by a hospital-based clinician. Okay, and then the only other sort of format editing would be the line, the final sub bullet point of when in doubt, contact online medical direction. My view of it would be that would make more sense as a rounded bullet and the last bullet shown under that whole section. And beneath, patients should have decision-making capacity, et cetera, et cetera. Because when in doubt, contact online medical direction is not an exclusion criteria, so it doesn't belong in that sub.
That one
Yeah.
definitely.
That's all I've had personally. Any other discussion?
the only other thing is, because we're getting ready to roll this out after the first year, and this may be particular to our area, but one thing we added in was to contact the behavioral health facility before you transport over there. Because, you know, if they go there and they just show up at the door and they say, we're not taking them, then they've got to drive all the way back to wherever to the back to the ER. It may be different here in the valley. I don't know if the behavioral health facility doesn't have a plans all but ours like depends on the staffing, depends on, you know, how full they are.
That's actually a part of the alternative destination rule.
Right.
Because you have to contact them.
Right, but it's not in here. That's why I'm saying if we're using it as a guideline. And for us, the way we were gonna write it up is do the same thing, and then we only have one facility, so we put their name and their phone number and that type of stuff in there. Is that something we want to put in here that says contact the facility to make sure, before you transport to the facility, contact them to make sure that they'll actually take them? Does it make sense? Yeah.
We did discuss that quite a bit at MDC. The access funded clinic, the ones that law enforcement take patients to all the time, don't really want a phone call. They have a no longer policy is just bring us patients. And so the feeling from MDC when this came up is, are we potentially creating a barrier versus making it more an operational thing for where you are? So depending on what you're, you know, for you geographically, that makes sense. You don't have a clinic that's going to definitely accept patients, but the thought being that if you have facilities that are willing to, we don't know the TTTGs have a lot of that operational piece in them. We kind of leave that up for the local area. So I definitely think that's part of an implementation plan and need to work on for sure.
Any comments on the phone? It's not an approval item either.
Yes.
All right. So next, can I get a motion to approve adding IV antibiotics to table 1, EMT drug box for paramedics? Yeah.
Okay.
Thank you. Thank you. All right, open for discussion.
Dr. Walker here.
Yeah, hey, Brock Walker here on the call, and Andrew Adamczyk is also, I think, logged in on the call. We're orthopedic trauma surgeons at Banner University Medical Center here in Phoenix with the academic medical group through University of Arizona. So we do orthopedic trauma here at the Level 1 University Hospital. And we just wanted to make ourselves available for a couple things. One is we recently put on a trauma symposium focused on pelvic ring management, polytraumatized orthopedic injuries, and pelvic binders. And if anyone ever wants to do any more orthopedic trauma education, we'd be happy to get involved with that kind of stuff. Try to increase the use of pelvic binders or sheets on suspected pelvic injuries. But this one was another thing that came out of that meeting was a lot of level 1s or academic centers are starting to kind of implement antibiotics for suspected open fractures or even just large wounds that are with gross contamination for antibiotics in the field for pre-hospital type stuff. So just hoping we could get this going here.
And so just for a point of clarification, are both of these cephalosporins intended for that one indication, suspected open fractures?
Exactly, yeah. So our general protocol is ANSEF alone for, you know, type 1, type 2 open, just small wound, bone barely through the skin, and then ceftriaxone is it used to be ANSEF and gentamicin for type 3 or, you know, bigger open wounds, more contamination, but gentamicin has a less friendly drug profile and side effect profile, and the implications of wrongfully giving it might be more. So there's a lot of focus on just switching it to, instead of ANSEF and Gent, to just ceftriaxone. And there's been multiple studies to say that it's pretty much just as good with less side effects. So a lot of hospitals are going towards ceftriaxone for type 3 or contaminated wounds or bigger wounds. So we're just simplifying it to be, you know, ANSEF for small wound open fractures, type 1 and type 2 type stuff, and then ceftriaxone for bigger wound, mangled limb, more contamination, farm injuries, water injuries, anything like that.
And off the top of your head, can you help us understand some of the bullet points from the literature in terms of how dramatically important is the timing of administration of these antibiotics, and why is pre-hospital now coming under scope there?
Yeah. Yeah, absolutely. So, I mean, that's our biggest variable in any research study that's ever been done on open fractures to affect outcome and ultimate infection is time to antibiotic. And, you know, our hospitals are very good. As soon as they hit the trauma bay or the ER, they get antibiotics. And it's kind of a jump to say that, you know, sooner on the field is better to make a clinical difference. It's definitely sooner in the hospital has been better, but no one's ever really successfully studied the differences between pre-hospital versus as soon as they hit the door, but it's kind of a logical leap to say the sooner the better based off of other studies that have been done within the hospital on the timing. There's certain things that are probably more important than the timing, such as like quality of debridement, that are harder for people to study because everyone in their surgical note just says it was debrided and it's hard to measure. But from the things that we can measure, time to antibiotic has definitely made a difference in the literature for orthopedic, for open fractures and the risk of infection. So our hope is to get this implemented and then try to do research to try to show the difference it makes from an academic standpoint. So that's our goal and part of why we want to get it implemented. One, because we think it's going to help outcomes, and two, because we hope to study it.
This is Erin O'Connor. I just had a question, I guess. Well, I know there's been literature on pre-hospital antibiotics for sepsis, and even meta-analyses have shown that there's not, my understanding is there's not a lot of benefit in that particular diagnosis. So I think I had the similar question about what is the current existing evidence. It sounds like there isn't great evidence. My only other concern is if they're, I guess, worried about antibiotics, will they be maybe distracted from other things like pain control, and then also the other concern is antibiotic resistance if it's ever used inappropriately. So just kind of considering some of the possible downsides.
Yeah, so I agree, and the timing of antibiotic delivery and sepsis is kind of a much less distinct thing than an open fracture. Like the time zero, we have an open fracture, and that's been studied well for when people hit the hospital, or especially when people are getting transferred between hospitals and the antibiotics is delayed. Like that has absolutely been studied, and time to antibiotics matters for open fractures because that's like a time zero. We have an open fracture. Sepsis is kind of a little bit different entity or animal than open fractures, but time to antibiotic from like hospital transfers and delays and that kind of thing has definitely shown a difference for infection rate. So I can't promise that doing it in the field is going to be different than if they got put on an ambulance and got to university 15 minutes after their open fracture, but it's a logical jump to say the sooner the better from the available stuff we have on open fractures. For side effects or for wrongful use of it, I think there's almost zero concern. We do anytime someone has a laceration anywhere near a fracture in our hospital, we treat it as if it's open till they get to the operating room, and then we prove that it's not. So our standpoint is very much we would rather give 10 people antibiotics unnecessarily than miss one that needed it that was actually open. So that's our standpoint there. I sent to Shelley a few research articles on other centers that have implemented this or other communities that have implemented this in terms of like administration or side effects or anaphylactic reactions or that kind of thing. And so there's data out there on other centers doing this safely or implementing this safely, and that it's been well accepted. So it's not a novel thing compared to other centers.
I've got a hand here in the room.
Me? Okay. This is Amber for all these online. I have several concerns. So my initial concern is the use of putting antibiotics on as a just general line, meaning that any antibiotic then would be fair game for ambulances to carry and paramedics to administer for any indication. So I think that the literature on sepsis, as we discussed already, is pretty clear that there's not a significant benefit to giving it in a pre-hospital setting. My concern in an open fracture setting is that in trauma specifically, there's often limited resources, and particularly with polytrauma, and there's a lot of other priorities on scene, such as managing traumatic brain injury, managing airway, and I think that the risk of taking away from other life-saving procedures to provide a medication that there is currently no evidence of benefit in the pre-hospital setting, I think for me would be a clear no for this agenda item.
Anything else?
No, that.
All right, so we got Dr. Brand on the phone.
Yeah, the other point I agree with all of what Amber said. When you're looking at it, and I know you had brought up that ceftriaxone is in the studies at least looked better. I mean, that's an infusion over 30 minutes. So for the majority of it, even outside of rural, and you're going to need a pump, but it's going to be, it's not going to be that beneficial. And as far as ANSEF, it's even over 5. So you've got somebody sitting there trying to push a drug in over 5. And I'd be worried that they're not taking care of all the other immediate issues that would need to take place.
Thank you, Dr.
Brock Walker again. So we're not hoping that this would be a mandate or something that anyone's going to hit the door and say, hey, why didn't you give antibiotics? This is something we're hoping to make it available, that they have the option or capacity or permission to do when it's appropriate. So isolated open tibia fracture, not needing a bunch of airway stuff or whatever. If they have time and they're transporting them anyways from 40 minutes away or 20 minutes away, to hang a bag and with whatever fluid they're giving them or whatever else. So that's the goal, not to make it a mandate.
Thank you, Dr. Gamer.
Yes, I would be in favor of adding this as an optional item as depicted. When I first heard about this, Dr. Chris Salvino, who's now out at Lake Havasu, asked if this had been brought up at PMD and Medical Direction Commission, et cetera, and he was certainly in favor of this 3 or 4 years ago. I think that urban medical directors can parse all these issues with the local trauma centers and assign priorities and on a case-by-case basis. Decide whether this is for them and their agencies. Out in the rural area, I think this is clearly something that could be of benefit if all the other priorities were addressed and appropriate training on the administration of antibiotics, how to do it, pump versus push, these sorts of things would be valuable for rural and wilderness areas. Thank you.
I've got Philip Hannon next.
Hey, Dr. Holder, this is Philip Hannon, one of the EMS physicians down in Tucson, also part of Banner. I have 2 questions. One of them is, you mentioned that there's a couple agencies already doing this research in antibiotics and open fractions and ground ambulance. Do you have access to that data or any way we can look at that? And secondarily, is this already in the IRB approval process? Do you have this going through kind of the local IRB to make this more palatable?
Yeah, I sent three articles to Shelley about where this has been done and how it's been implemented. And most of the research studies were just to say, were there any anaphylactic reactions or some other reaction to say, safety concern. Nothing has really looked into like long-term data of the patients that got it versus didn't yet. But to someone's point earlier that says, that said something about not implementing because we don't have data that it matters. Like we can never get data to show that it matters if someone doesn't implement it. So that'd be the counter to that. So if Shelley's able to send it around, the other studies from the other centers that have implemented this, basically they didn't have any instances of a bad reaction or side effect or any undue harm by implementing it was the gist of it. No question about the IRB. We have not done anything with the IRB type stuff because we do not have anything approved yet. So from a community standpoint, the goal was to make this an option for people and then to figure out the best way to go about studying it.
Dr. Godthinker.
Hey, thanks everybody. I guess a quick question, I might be a little bit ignorant about it. What's it, any storage issues regarding these antibiotics, refrigeration, UV, any of those kind of things? I'm just not so familiar.
Well, there's some reconstitution issues, if I'm not mistaken.
But that's just with saline.
Okay, yeah, okay.
Right. I think we have to do other things.
No, perfect. And that's just, again, like I hear both sides what's going on here. I'm not just trying to think logistically how feasible it would be as well. So I appreciate the input.
Yeah, no,
Dr. Gaither.
The logistic issue is why I brought it to this committee to see if it was something people were interested in. We also have included Austin Mock, who's one of our head pharmacy guys here at the University Hospital, who did the drug profile and sent that in the minutes here. So he's on board and can help with like the antibiotic, stuff.
Dr. Gaither?
You're muted, Josh.
Oh, whoops. I turned on my camera, not the other one. My apologies. I just want to follow up on Philip's comment on research. I think it would be very, very important to clearly, in this case, avoid that term. As someone who has multiple ongoing exception from informed consent emergency medicine research trials currently in operation, this would clearly require an EFIC type of research protocol should this be a research project. You can't just, I shouldn't say you can't, ethically, it would be inappropriate to start a new practice with a plan to study it and not inform the community that you are studying them. That would be fairly commonly considered to be unethical. So that's it.
Dr. Johnson?
I'm just wondering if we didn't do this, could they potentially do it as a pilot project like we did with ultrasound IVs in the hospital? I mean,
Would there be another mechanism that you guys are
if they're
aware of?
wanting to do this study to see if it's efficacious.
So we do have the pilot program process, which would go through kind of medical direction council to provide feedback to the director. So that was the established process that we actually added to the bylaws, correct? That the pilot program would go through MDT to vet, to make a recommendation to the director, to then determine whether or not that would be approved.
And that would include work involving a medication that's not currently within.
That would be, my suggestion, because I kind of agree with Amber. It gives me a little heartburn to blanket approve something that we have no research to back it up with. But it could potentially be good, but I wouldn't want to shut it down completely because I think maybe doing it as a pilot project would be a better avenue than just approving it across the board.
Anything else?
So just to comment on the research side, so that would be true. I mean, there's no argument that an open fracture gets antibiotics. So we are not reinventing the wheel in terms of saying this fracture or laceration I can see the tibia through should get antibiotics. So now we're just talking about the timing of it. To say we're going to go and study it at some point would require IRB approval, but you take the research side out. Let's just say we weren't going to ever do any research related to this topic. I'm just talking about getting it approved to go ahead and get it in the field, which has been done elsewhere. We will handle studying it with IRB approval once we decide to do that, whether it's retrospective or prospective, but just giving antibiotics in the field, take the research side out of it. That's what we're trying to get approved.
Brian?
So yesterday I learned what a type 1, 2, and 3 fracture was because I did not learn that in paramedic school. And so at least off the drug profiles, and I know I'm getting ahead, but I think it needs to be part of that needs to be considered because type 1 is a fracture with a 1-inch laceration or 1 centimeter laceration, I think is what I read yesterday. The description of an open out femur is different than me going, well, that's a fracture there with a 1 centimeter laceration in the field. And it apparently requires two different antibiotics. And we use cefepime for type 3s at FMC because we've done a bunch of these studies that there's a name for it that I can't think of.
Antibiogram.
Yeah. And that's what we feel covers our group of populations. So now we're adding another one. Now people are having to carry two different sets of antibiotics to cover the different types of fractures. And so the cefazolin, that's the correct pronunciation. It comes in 25 1-gram vials from Boundtree, and you can only get it in the case Y, which is like $287 roughly, I think. The ceftriaxone you can get in individual vials at $9, but that's adding on more. And this has come up in discussion on some other drugs we've looked at adding is that some then if the medical director decides, yes, I want to do that, it's adding a bunch of expense to whatever agencies are involved in now and having to purchase those items, many of which may expire if you only do the most obvious open type 3 fractures, right? Or fractures that are over 8 hours old, I think go into type 3s also. So I'm a little bit concerned about having to classify those in the field and then having to carry 2 sets of antibiotics to cover the different types of fractures, open fractures.
So what I hear you saying, Brian, is that agencies may be hard pressed to adopt this, even if it were made optional and approved on some state level. The question would be adoption. There's some regional nuances in terms of the different antibiograms across the state of Arizona and whether these 2 particular medications would be considered first line in those regions. And some of those logistical concerns, right?
Well, yeah, and then I think you would have to leave it in a general class of antibiotics rather than coming back as I think one suggestion and adding these as individual names because now we've got people getting ceftriaxone. If Dr. G decided he wanted to do that when what we're doing in our facility for type 3s is to give ceftriaxone. So.
And just to clarify, I know Shar, your hand is up. One of the things with the way rule is specified in Arizona, if we list an agent, so broad category antibiotic, that would include any antibiotics. So that's kind of that clarification. So that could include vancomycin, tetracycline, it could include anything. So it has to be very specific. I think part of it is just the way that the rules are actually written in terms of medications and medications. So antibiotic in this format would be somewhat difficult to align. The other component is once you approve a medication and it's in the drug box or drug table, it's an approved medication, it can be used for any indication. So I think that's the other part that's a little bit tricky as well. And we have had that discussion both at PMD and MDC when there's been a discussion on adding medication. While we can create a drug profile and say the recommendation is to use it for indication A, B, and not indication C, an agency with their medical director, once the drug is approved, can administer it in any format for any indication. So we always have to take those things into consideration as well.
Just one other logistical consideration would be how many agencies carry IV pumps. I don't think that it's very widespread, and the majority of these antibiotics require an infusion.
Yeah. Dr. Brand on the phone.
Oh, just one other question on it. Are we able to do it as a pilot? I mean, going back to it, I brought up before both the pumps and the fact that once it's out there, it's out there. But is there? I mean, would we get enough? Are there even enough fractures to how many do we get that would warrant a study if you want to do it like that as a pilot? But I think that I don't know how you authorize it for just across the board blanket.
Yeah, certainly. If they were to explore the pilot project process, then the geographical limitations of that would be something to consider. I thought I saw one more hand on the phone, but it's gone now. Falcon.
Yeah. Hello, thank you. It's Chris Falcon from Banner Tucson. Just another perspective on this, just because information I get from some of my agencies, I just kind of want to echo. I believe it was Dr. Bradley was speaking about. If this is approved, this is something that wants to be added to table 1, I would like to echo, it does need to be very specific to the medication. Keeping it broad like this will run consistent with the hospital agent table on table 3, antibiotics. It's unrestricted. So it would run the same if we put it on table 1 just as antibiotics. So I would be very careful about that if this gets approved. Secondly, on top of this, we're talking about utilization of infusion pump with this. Currently on the scope, it is an STR for paramedics. So my recommendation would be kind of running consistency with this. If this is something to be approved, maybe a consideration would be an STR with training specific to the open fractures with infusion pump. Because if we put it on there just as an open game, nationally component, there is really no education really on giving antibiotics, indicators for antibiotics, stuff like that. So that education is really not there beforehand. So I think moving forward, if this is something, maybe making it an STR in conjunction with the pump, with the specific training on the open fractures. That's just from another perspective, from information I receive from my agencies and the type of questions that they ask me. It's just an anticipated view.
Thank you very much for your comments. Go ahead, Amber.
Just another thing that we typically would consider when we're talking about adding anything. Obviously, there's the discussion about the potential benefit or any evidence-based benefits that we would have. The other side of this is any potential downsides, which I think we also don't know a lot about. I think the things that we have seen in the past with things like even IV placement, causing delays in transport for things like trauma patients. And I think this is the potential for risks in that area as well as we consider adding additional sort of unproven strategies to manage things that could result in delays in transport or other things that we know have downsides in patient mortality and trauma.
Well, let's go ahead for the sake of time. If I don't have any other burning comments, so we'll go ahead and put this to a vote. And again, these are kind of split up into 3 different items. We're just referring to item F right now, which is to approve adding the term IV antibiotics with no specifications to table 1 EMTT drug box for paramedics. All those in favor of approving that, say aye.
Aye.
Any opposed, say nay.
Nay.
I don't see any abstentions on this vote in particular. Any abstentions? All right. I don't believe we need a roll call vote on that. It seemed pretty good. Yeah. So the motion does not pass. And so given the non-passage of item S, then there should be no need for further discussion of G and H at that point. All right. I do want to thank those who came in on the call to help us discuss these items. Just to summarize, there is a pathway in the state of Arizona to conduct pilots, even on medications that are not currently approved for EMCT use. And so we certainly extend an open door and an open hand to explore that further. And it's not lost on the medical directors in the room that antibiotics are an area of gaining interest in EMS, but it's still very early days, even for some other indications like sepsis. And so that concludes the items for discussion and actions. Any items to be considered for the next meeting, please send those to Shelley. Her email will put on the agenda. Any calls to the public? All right, hearing none. Upcoming events, November 15th and 16th is the Tribal Opioid and Substance Abuse Conference, in Scottsdale. So that is on the agenda there. November 16th and 17th, the 14th Annual Southwest Trauma and Acute Care Symposium. I've been hearing lots of good excitement about that. December 7th is the AIMS CE Fall Forum, and that will be on a virtual platform. And then March 4th and 5th, NAEMS's 15th Annual Arizona Pediatric Symposium. And then you had mentioned NAEMSP Scientific Assembly in January. Do you have the exact dates on that?
It's the 8th through the 13th. The pre-conference days are early. The conference runs like Thursday, Friday, Saturday.
And that's in Austin?
Austin.
Yeah. Otherwise, please visit the Bureau's news and conference pages for additional upcoming events and the training programs pages for upcoming CE opportunities. With that, the next meeting is March 21st, 2024 at 1200 hours, and otherwise we'll adjourn. Thank you very much.
Your comment, do you have another comment? Go ahead.